Hey, good morning and welcome to the Space Coast Transportation Planning Organization's Health and Equity in Transportation webinar for Mobility Week, FDOT's Mobility Week 2021. I am Sarah Crom. I am the Senior Transportation Planner with the Space Coast TPO and going to be your moderator for today's session. So before we get started, why is it important to talk about health and equity during Mobility Week? So Mobility Week is a celebration of making smart, efficient, and safe multimodal transportation choices in order for a transportation system to be smart, efficient, and safe. It must be planned in an equitable way with quality of life and community health and resilience in mind. Equity is fairness in mobility and accessibility to meet the needs of all the community members. By ensuring equity in transportation planning, we can increase the quality of life, community health of our communities through increasing social and economic opportunities. Equity in transportation does not mean equal. It is considering what is the right fit for that community. This could mean some communities need better access to transit, while another community may need sidewalk gaps completed, and then another may need traffic calming techniques. It's thinking efficiently about what that community needs in order to function. I am very excited that you all have joined us for this webinar and look forward to listening to our speakers expand and build upon these concepts this morning. With that, I would like to review the agenda and introduce our speakers. So right now we're doing welcome and housekeeping. So welcome everybody, and just a couple housekeeping items is for those that are unfamiliar with GoToWebinar. There is a question box that you are able to engage with us throughout the presentation, and we look forward to receiving any questions you might have. So we will then move into our presentations following this review. Then we have a panel discussion to expand upon any kind of ideas or concepts that we might further want to discuss. And then finally, the opportunity for you, the attendees, to ask Q&As and wrap up. So I would like to introduce our presenters today. We have Angelica Keene, a Community Development Extension Program agent with the UF-IFAS extension in Brevard County, and she is going to be introducing the concept of health and equity in transportation this morning. We have Roberta Fennessy, who is the Director of Planning and Design with FHB and is going to reviewing their Healthy Mobility tool. And then finally, we have Sigal Carminati from, she's a city and regional planner with Kittleson Associates, and she will be reviewing using data to look at transportation disadvantaged populations. So with that, I'd like to turn it over to Angelica.
All right, good morning, everyone, and welcome. Thank you for joining us today. My name is Sarah said, is Angelica Keene, and I work with the University of Florida Extension Office. My presentation today is going to be an introduction to health and equity in transportation. So if we could, next slide, please, Sarah. We can't have a conversation about health and equity without first starting with a shared understanding about health and a common definition. The understanding that health is not just about disease is critical for accepting what it will take to advance health equity. Health is dependent on a complex system or set of systems that intersect and influence one another. So according to the World Health Organization, health specifically is defined as a state of complete physical, social, and mental well-being, and not merely the absence of disease or infirmity, meaning that we have to move past this simply if someone appears healthy or looks healthy or isn't sick, they are healthy. There's much more complex factors that come into play. Next slide, please, Sarah. So once we kind of have a definition of health, we need to understand the factors that determine health. Now, there are many different models, and there's a ton of research on this one, but this is kind of the common model that most use. And what I would like you to note here is that clinical care only accounts for 10% of the total, and health behaviors only account for 30%. Yet when we often equate healthcare, nutrition, exercise, wellness, these are all the traditional terms that we use when we're defining the word health. But as you can see, the majority of the wheel, 60% of what determines our factors of actually how healthy we are actually outside of the traditional healthcare system, the traditional discussion, and that's what we're here to try to frame. Next slide, please, Sarah. So what is the other 60%? These are conditions that are the prerequisite for health, meaning that human beings need peace, shelter, food, income, education, a stable environment, sustainable resources, social justice, and equity. When any of these are missing, people struggle to be healthy. These are often referred to, these identities, these conditions we talked about are often referred to as the social determinants of health, which is important to point to understand as we move forward. Because the thing is, if they're socially determined, then we can make changes to them, which can impact people's health. Next slide, please, Sarah. Now that we have a defined health, and we have understanding of what the social determinants of health are and how they affect an individual's health, what does that mean health equity is? So health equity is this idea that all people can obtain healthy, thriving lives and well-being free of preventable disease, disability, injury, and premature death through this idea of focused ways to address health inequities. Health inequities. Next slide, please, Sarah. So health inequities are the difference in health status or in distribution of health resources between different populations, groups that arise from social conditions in which people are born, grow, live, work, and age. And as you can see on here, it's supposed to be health inequities, but I have the wrong word on the slide. As Sarah talked about, these concepts of inequities and inequalities are interchangeable and sometimes autocorrect. So I apologize that it's incorrect on the next two slides, but I'm discussing health inequities. And again, that's this concept of bringing people what they need. And so health inequities is people not having the resources that they need and the time that they need them. So next slide, please. So what causes health inequities? What you're looking at is kind of a concept from the University of Florida on the structured root causes of these structural inequities. So what you'll see on the outer layers is a list of some of the ideas or root causes that might cause these inequities. Now understand that this is not an exhaustive list. This is just some common things that when unfortunately decision makers use their power and through this lens to establish the norms, the policies, the practices through any of these lenses, then people systematically get denied access to resources and services which actually prolong the lifelong health and well-being that we want them to have. So again, thinking about this as kind of a ring, some of these things, whether consciously or unconsciously, when decision makers use this concepts or these terms or these ideas to view their decisions, it sometimes skews things in a negative. And what I mean by that is, here's some examples. So for example, a freeway built with limited access for a poor urban community, but an easy on-off access for a more affluent suburb neighborhood. This results in businesses and jobs that locate near the freeway, which again creates that consistent cycle of the well-being for that affluent, but the disadvantage for a poor community. Another example of these types of decisions might be when a full-service bank chooses not to locate in a lower income, high suburban area. What happens is a lot of the payday loan businesses move in to fill that gap, and traditionally these are more expensive and again create that cycle of disadvantage for that community. So you can see how everything is interconnected, from how we make our policies, procedures, and norms. Next slide, please, Sarah. So what can we do about it? Health is truly a community effort. People have the power to change their communities. We need to recognize when and where certain communities are being excluded from the decision-making process and ensure that all people have the opportunity and capacity to participate in creating those healthy communities. We need to shift our thinking and acting that this kind of big response requires, kind of looking at these primary problematic areas. So building public understanding of these areas and creating health is essential. We must work to change the narrative so that people understand health is created in a community by people working together to create social and economic conditions. The next thing, oops, sorry, go back please, Sarah, sorry. The next thing is to increase the expectations that these conditions can change. Understanding that public and political will is necessary because there's going to be tough decisions because this is a complex issue. So competing forces are bound to happen. And finally, having that accountability. So once we say we're going to support a neighborhood, following up, interacting with them, making sure we do so. So what does that look like specifically for transportation? Next slide, please, Sarah. So specifically for transportation, some ideas or suggestions or health equity might be improving pedestrian infrastructure or increasing public transportation services in low income or minority communities, improving connectivity. It could be using roadside barriers or vegetations or bottlenecks to reduce the impacts of pollution on those communities located near high volume roads. It could be offering reduced public transportation fares for students, youth, as well as employers working with their employees to promote that public transportation component, making it easier for them. Could also be targeting beyond demand response services towards high communities with, say, the elderly or poor access to shops, so taking people where they want to go. And then finally, can be addressing that housing affordability in regional strategic and promoting ways, meaning that we're offering different variety price houses for people of all stages of their life. So these are some examples of some of those norms, those policies, and those practices that can be put into place when we're thinking about health, equity, and transportation. So in conclusion, health is more than an individual's responsibility. It is up to all levels of community to work together to address the complex factors that affect health and work to create policies, norms, practices that allow all people to obtain that healthy, thriving well-being. This, in a nutshell, is health equity in transportation. Again, my name is Angelica Keene and I'm with the University of Florida, and what you see on the screen is my contact information. Thank you very much for letting me present.
Thanks, Angelica. Thanks, Angelica. Next, we are going to hear from Roberta Fennessy with VHB. And Roberta, I am going to give you the keyboard and mouse controls. Okay.
All right. Thank you, Sarah, and good morning, everyone. I'm Roberta Fennessy, Director of Planning and Design at VHB Orlando. Thank you also to Space Coast TPO for inviting me here today to speak about VHB's healthy mobility model and how we and our clients are utilizing this tool to make planning decisions that really positively impact public health and specifically the presence of chronic diseases. Our team set out to develop this healthy mobility model really to further our commitment to plan and design communities in a way that makes it easier for people to live healthier lives. And these became key drivers for a lot of the work we have been doing going back to 2015 and our involvement with the Paramore Community Neighborhood Plan. So what this model has allowed us to do is correlate a lot of what Sarah Angelica just highlighted, some of these social determinants of health, demographic, commuting patterns, land use, urban design, transportation network factors, to community health outcomes. And we do this by leveraging big data to contribute to the decision-making process and in a way that's scalable and transferable. So I'm going to start this presentation today by briefly explaining why we developed this model and also the methodology behind it, and then close with some applications. This should be no news to any of us by now, but the US has been experiencing a consistent growth in both the rates of chronic disease and healthcare costs. And we continue to be behind other countries in public health spending. And public health initiatives are focused on prevention and population level interventions, while healthcare spending focuses on treatment and individual care. So it's kind of the notion of it treats the symptoms and not the cause. Here's some data about how much it costs us to take this approach of healthcare as opposed to public health. We spend a lot of money in the US on individual care, and we don't get a lot of return for our chronic disease rates. And it's increasingly understood that this is not only it's not only the social, genetic, and behavioral factors that influence our health outcomes, but also the environmental factors. So where you're born and the environment you're exposed to and have access to is highly influential to health outcomes, specifically the chronic diseases we're going to focus on. And the disparities in the quality of the built environment and the planning decisions are revealed on the health outcomes of communities. So as planners, we are responsible for how cities grow and change. We're responsible for how people access resources that are beneficial to health, such as jobs, transportation, education, and affordable living. And we're also responsible for creating policies that are equitable and sustainable. So if we don't also account for how these planning decisions influence health outcomes, we're not really doing our job to its fullest potential. And this is where healthy community design comes into play. And this is an approach that aims to plan and design communities and the built environment in a way that makes it easier for people to live healthy lives and use planning as a tool for public health, most importantly, prevention. So over the last 5 years, VHB has teamed up with some industry leaders to create a series of healthy community design symposiums that are focused on the integration of health and planning with the goal of addressing the question, how can we best incorporate healthy community design principles into our work to ensure that investments in infrastructure have a profound positive impact on the health and resiliency of our communities. And here are some of those established healthy community design principles that we've been applying in all of our work. And while they're adopted and embraced by the industry, the reality is that they're largely qualitative and not quantitative in nature. And so with this in mind, we began to ask ourselves, how can we use data and data that can be leveraged to bridge that divide of qualitative approaches and solutions that have quantitative results. So I'm going to talk about a little bit about our methodology behind developing this model. I ask you all to bear in mind I am an urban planner and not a statistician, so some of this hurts my brain, but it is fascinating and really phenomenal to work with. And so we set out a few goals in developing this model. Firstly, to analyze land use, urban design, mobility factors that affect community health, sort of the core, kind of our core planning principles. Also to establish a baseline health assessment and trends for a community. And then how could we forecast and likely community health outcomes or conditions and identify and prioritize improvements that can contribute to better health in a community. And we've been referring and utilizing this model in methodology in 2 tiers. So the first tier analysis is really about understanding risk and vulnerable populations. What does the profile of health look like in a given community? And we started out by taking the CDC's 500 cities data. And if you're not familiar with this project by the CDC, it provides city and census tract level estimates for chronic disease risk factors and health outcomes across 500 major US cities. So we started out with this data set. We ran statistical testing on the CDC's health data along with census demographic and socioeconomic data, which allowed for us to model the entire state of Florida to be analyzed, including the areas where that health data was not available. So the VHB model, mobility model, estimates the percent of population affected by each of the 6 health criteria and establish an output health risk score. And as you can see, the health criteria, the chronic diseases, the 6 of them that the CDC highlights are high blood pressure, asthma, heart disease, diabetes, high cholesterol, and obesity. So in short, this is the level of information that the 500 cities data provided us. You can see where the major cities in Florida are highlighted. And after we modeled it or projected it across all the census tracts in the state of Florida, this is what we get. And Tier 1 is all about risk assessment. So this is a planning level tool that can give us an idea of what the risk profile looks like in a community and what census tracts are more at risk and what are they at risk for with regards to the chronic diseases, right? So here, I won't run our dashboard during this presentation because it'd probably crash our webinar, but here's a screenshot of it. This is what it looks like. It's very user-friendly. You see kind of the Tampa Bay area, Pinellas County, Hillsborough County, and you can, I've highlighted a census tract right in downtown Tampa, kind of the Hyde Park area, and it gives you that risk score for that census tract in comparison to the other census tracts, both in the area and throughout the state. And you can also see you get an overall risk score and then also a discrete risk score for each of the diseases, each of the chronic diseases we look at. The second tier analysis is where we look at the influencers of that risk profile. So after the risk is identified, the tool assesses built environment factors and determinants of health to examine the relationships to health outcomes. So this is spatial built environment data and variables that are brought in and analyzed to identify the correlations and the relationships to health and control for socioeconomic factors. So you see some of these variables listed here. We've looked at lots of guidelines such as New York City Active Living Guidelines, LEAD for ND, APA, ULI, well certification guidelines to come up with some of these variables. And really the sky's the limit. As long as it's spatial data and available in a census tract level, we can plug it into the model and create those relationships. So it allows us to ask what is most correlated with overall health, which built environment factors have the greatest impact on community health, and what are socioeconomic factors that need to be addressed along with these built environment factors. So these queries can inform decision-making from interventions to alternative studies or policy changes with regards to community health. So how are we using it, and how can, and more importantly, should this model be used? So we've done a lot of work with Metro Plan Orlando on its Metropolitan Transportation Plan update. And as part of this work, they used the Healthy Mobility Model to identify the locations within the region that are at the greatest risk of chronic diseases and use this information to screen alternatives and help prioritize the improvements that contribute to better health outcomes through a scoring mechanism for each of their proposed updates in their MTP plan. So this is kind of that tier 1, right? Look at the risk assessment of the region and based on geographic location, you can score these alternatives and these updates or interventions accordingly to help prioritize decision making. So for this, we didn't just use the health mobility model, census and chronic disease data. We integrated LOTUS data, which is from the East Central Florida Regional Planning Council, and includes a lot of built environment data from pedestrian mobility to transportation network safety variables, land use, location intelligence. So really it had over 20 roadway attributes and 20 points of interest. So really added a whole other layer of built environment and transportation data. We also, in addition to the use in the MTP process, we worked with MetroPlan Orlando to perform a more detailed analysis within the West Orange Healthcare District, which is one of their special project areas. And the Tier 1 analysis ran that initial vulnerability assessment of communities based on the projected risk of the 6 chronic diseases. And then it estimates it through the geographic distribution of these diseases. And generally, generally, what we saw is that the areas north of the Florida Turnpike, so kind of the north right-hand quadrant of these maps, had a higher projected prevalence of the chronic diseases analyzed than, say, the Horizons West and areas south of the Florida Turnpike, which you can see sort of the larger swath of green. More specifically, the town of Oakland and the area in the northeast portion, which includes northern Ocoee and south of Apopka, were areas with the most vulnerable populations to chronic disease. And again, back to the large green swath, these are areas around Dr. Phillips and Bay Hill, but also we considered it took into account there's a lot of Disney property that fills that area, and these had a lower projected incidence of chronic diseases than the district average. So again, this is a planning level tool. It still requires us to look at this data and interpret it and ask questions and understand some of the existing conditions that are leading to this analysis, right? As expected, though, the analysis also showed that poverty levels consistently had a statistically significant relationship to the prevalence of the 6 chronic diseases and general health outcomes. Now, our Tier 2 analysis provided correlations between mobility and built environment factors and projected health outcomes. So again, we layered in some of that Lotus data that had some of these specific built environment and mobility variables, and analyzed these factors to review their relationship or their correlation to projected health outcomes. And the factors we analyzed for this review included demographic and socioeconomic data, including median age, poverty, educational attainment, and mobility network data, which included speed limits, number of vehicle lanes, right-of-ways, destination accessibility. You can see here on this list a lot of those variables that we looked at. The analysis, I'm going to get into some statistics here, provides a T-score for each factor in relation to each of the disease. And the higher that absolute value, the stronger the correlation and more confidence that there is this correlation which is significant. So what are some of our key findings from the MetroPlan case and our work with MetroPlan? So first, access is key, right? So there's a clear relationship between proximity and access to public parks correlated to better health outcomes. And so we can start asking that question: how do improvements and projects in this district enhance this access so we can improve the health outcomes for more neighborhoods and for more geographies? Also, what is the story behind the data? Again, this is where we as planners need to spend time looking at this data and understanding, what are these relationships? What's the deeper story and the history that may need some, additional explaining and understanding. So one factor that we found was interesting in the West Orange Health District, it showed strong correlations with multiple diseases, specifically blood pressure and asthma and obesity, was vehicle lanes. So the Tier 2 analysis indicated that the greater the number of vehicle lanes, the greater the projected rates of these diseases. Interestingly, however, the opposite correlation was found for right-of-way width, which showed the greater the right-of-way, the lower the projected rates of these diseases. So a possible explanation we came up with is that, a wider right-of-way could mean more lanes, but not necessarily. Wider right-of-way Right of way could mean there's wider sidewalks, there are bike lanes, there's a trail system providing for active transportation options, or it could mean there's a median or buffer to sidewalks that increases the comfort of pedestrians and cyclists, and again, encourages more people to be active and ride or walk along these corridors. Or it could simply mean there's wider shoulder and that people can utilize that as a bike lane or drainage swales. Um, but not at that direct relationship that a larger right of way immediately increases the width, but does not necessarily have to mean it adds vehicle lanes. Uh, and lastly, keep it local, right? So understand the local context. This is kind of planning 101 too, and translates here where, we also saw that the relationship to healthcare facilities in this community was not the same as what we've seen in other areas. And so we realized we needed to further filter and look at that local data. Why were some of the traditional outcomes we've seen for neighborhoods and census tracts in close proximity to healthcare facilities not showing those same relationships in this case. So we've learned a lot from using this model ourselves, and particularly how the model should not be used, right? So we have to be really cautious with small sites. The model may be used in identifying land uses that confer health benefits, but with small projects, it'll be hard for them to have population-wide benefits, and you'll see, a lot of noise. This is also a model that compares census tract to census tract to larger geographies, districts, regions, the state, and everything. Also be aware of geographic scale of data variables. All the data sets need to be normalized to that census tract level so that we are working with apples to apples. And the model should not be used for just built environment indicators, right? That will, innately put some bias into our analysis if we're only looking at the conditions of the built environment and sort of these, spatial indicators. We really need to account for socioeconomic factors so that we're actually understanding relationships of a community profile. And lastly, but most importantly, is that correlation is not causation. So it should never be used to say that a project will improve health outcomes. It's only intended to look at those relationships, right? And one of the first runs we did of this model with the city of Orlando, where we looked to see if the presence of electric vehicle charging locations was correlated with improved health. And sure enough, it was, right? But we had to take that deeper dive and look to see, it wasn't that one led to another. And if the city goes and installs electric vehicle charging stations in neighborhoods, their health profile will improve. It was just that where the city had installed them were already areas with an improved health score, right? A higher health score. So remember, this is a risk assessment tool, right? To show and highlight relationships. So how should it be used? Its primary function and intent is to establish that baseline health profile for a community so we can understand, what are the existing diseases and trend data. We can go back, 7 to 10 years now with the census and the geographic distribution of those conditions. We can use it in neighborhood studies, transportation studies. We can get down to interventions and alternatives assessments. I think this tool is really powerful in that, kind of determining which environment changes would most positively be associated with better health outcomes. And lastly, for prioritization, right? For project prioritization, for resource prioritization, capital improvement prioritization. What are the factors that might have the biggest potential to move the needle? And another quick case that we had a lot of success using this model with, again, with working with MetroPlan Orlando, was on a project they were working with UCF on air quality monitoring report. And with the baseline projections that we had done throughout the city of Orlando, with the focused on the asthma risk one, they were able to use that data to prioritize where to locate the air quality monitoring stations. So again, a little outside of kind of traditional planning work, but really a great application of this tool in those informed decision-making areas. So I encourage you to think about how you think this model, this healthy mobility model, can help with projects in your community. For all kinds of projects, transportation, land use, long-range planning is really important. And we certainly welcome feedback, brainstorming. We're constantly updating and refining our algorithms. We've projected and modeled it through our entire VHB footprint, which really goes from Florida to Maine. So we've got census tract level data for all of those factors in place already. So it's really efficient now to run a lot of analyses. So I welcome any feedback. Thank you again for letting me present on our model, and welcome your questions at the end of the webinar.
Thank you so much, Roberta. We are now going to turn it over to Sigal Carminati. Give me just 1 second, Sigal, while I give you mouse and keyboard control. And
Sounds good.
Sigal will be speaking on leveraging data to understand transportation disadvantaged populations. All right, you should have mouse and keyboard control.
Awesome. Thanks, Sarah. And thank you everyone for joining me on today's webinar. Like Sarah said, I'm going to be presenting on the Transportation Disadvantage Index. And really, I want to share about how we can start to understand equity through readily available data, sort of like the past presentation, just with a bit of a different slant to it too. All right. So I'll first introduce what the index is, then I'll talk about how it's being applied in Central Florida and in Brevard County, and I'll end with a short discussion on the index's limitations and actions that you can take beyond the index to understand equity. So the Transportation Disadvantage Population Index aims to assist in identifying what those equity implications of transportation decisions are based on the makeup or the characteristics of the actual residents in a study area. It also helps prioritize transportation where the transportation network has a high number of people that have been traditionally underserved and have little to no mobility options. The data that's used for the index is actually from the Census Bureau and can be pulled at different geographical scales that make sense for the study area. So for example, if we're looking at a multi-county area, we can pull at the tract level, which are larger geographies, or you can get that more disaggregated data at the census block level if you're looking at maybe 1 or 2 counties. By using this score, what we do is capture multiple aspects, specifically intersectional aspects of a community's makeup. And this is sort of addressing that kind of issue of juggling between different maps that show each aspect singularly. So you'll have a map for poverty, you'll have a map for zero no household vehicles. You can toggle through each of these, but what the index does is create a composite score of all of these different criteria to be able to quickly just see the equity differences between geographies relatively quickly. So when we say transportation disadvantaged population, who are we really talking about? In this case, our application of it uses these 9 different criteria to define transportation disadvantaged. And just to further define a few of these, so overburdened renters are paying at least 40% of their monthly income on rent. People with limited English proficiency identified as speaking English not well or not at all. Our low income or poverty criteria looks at residents with household income 200% below poverty level. And when we say communities of color in this case, we're talking about those persons of all races and ethnicities beside white non-Hispanic. So a score is assigned to each geographical unit based on the population in that unit. So when I say geographical unit, for example, tract, the score is given to each tract in the study area based on the makeup of the population in that tract. So we have both household data and what I'll call person unit data. So data per capita are the equation that's being shown on the slide now. It actually normalizes all of that household data to get all of these different criteria in the same unit, the person unit. And since people can meet more than one criteria, like elderly and being low income, for example, so the intersection of these different criteria, the index actually counts people multiple times to create that composite score. And the only exception is, of course, elderly and youth. A person isn't able to meet both of those criteria. But what we get in the end, again, is a score for each tract or each geographical unit that's being looked at. So the highest possible score is an 8, so 8 out of the 9 criteria for each geographical unit. And that highest score is possible if every person in every household meets every criteria that's being used to create the score. So the index was used for FDOT District 5 as part of the Bicycle and Pedestrian Master Plan at the census tract level. So again, because we looked at a multi-county jurisdiction, we went with the tract level versus using block group. And the scores, which are shown in the legend, represent relative transportation disadvantage across the tracts. So what I mean by that is a higher number, which is seen in the darker blue color in the legend, means a greater transportation disadvantage for that tract as compared to the other tracts with lighter colors. So in this case, the highest score, highest quantile of TDP scores, which is that bin that's from about 2 to 3.4, that means that the tracts falling in this category contain populations with the greatest transportation disadvantage relative to all other tracts that are being analyzed in the study area. Oh, let me go back. Okay, further streamlining that, the transportation disadvantaged composite score was also used for the Space Coast TPO as part of the resiliency master plan that's currently in development. And we used the score to be able to focus the discussions that we're having as part of all of the community outreach and engagement we're doing as part of the resiliency master plan by being able to see a snapshot of the highest TD or transportation disadvantaged populations. We can focus discussions in those areas with those communities and community leaders. And the approach was streamlined from District 5 Bicycle and Pedestrian Master Plan by actually using a subset of the 9 criteria. So we used poor and struggling zero-car households, persons of color, households including a person with a disability, and persons over 65, specifically for the Resiliency Master Plan. And the TD Population Index information is only one of several data points that are being used for this plan to help us prioritize vulnerable and critical corridors that ultimately will have resiliency mitigation strategies developed for these top vulnerable and critical corridors. And just going into some of the limitations of the index, while it's a really great snapshot of the demographic makeup of residents, it doesn't show where people are actually traveling. So what specific corridors are being used regularly by residents and specifically transportation disadvantaged populations. Also, as we know, using census data geographies, it doesn't really tell us where people are living in that tract or block group. So residences are not spread out evenly across that geographical unit. And what that means is that some transportation disadvantaged populations might live immediately next to the transportation facility, that corridor, in a tract, for example, while another TD population might be much further away. And that's not something the score necessarily captures. And since the index uses the relative population in each geography, A higher score might be assigned to a geography that's less populous, but has everybody in that geographical unit meets one or more of the criteria. For example, there's 10 people in one tract, but they all meet one or more of that criteria. They might get a higher score than, let's say, a tract with 1,000 people, where half of them meet one or more of the TDP population criteria. So even though that tract with 1,000 people actually has more absolute number of people who meet a TD population criteria, the tract with a smaller population will get a higher score. So it's just important to understand these caveats when looking at a map of these scores as a snapshot. And just thinking beyond the index, while I love data and I'm very much a data nerd, and I know a lot of people on this webinar are, there's a lot of other things that can be looked at as well to really understand who makes up the community. So like I presented today, there's different criteria that can be used to understand your community, like the 9 that I showed, or the subset of 6 that are used for the Resiliency Master Plan, but also other subsets of criteria can be used, sort of like the health information that was shared in the previous presentation, or maybe choosing another subset of criteria based on what makes sense for your study area. So another great practice is to correct for the higher TD scores in geographies with a lower population, like I was talking about in the last slide. It's also really good just to have the absolute population numbers for each tract accompanying the map or the figure if it's being put in a report or shared in a presentation. It's handy to have that input and background data available, especially if you're trying to share this information with the public or decision makers, just to know what's going into the score. And while the index is helpful as one data point to understand where TD populations live, or where TD populations are concentrated in a study area, it's important to really experience the place yourself. So the score isn't a data set that would replace going out there into the field, having conversations with the community, or even just understanding the actual trips that people are taking. It's one data point out of a whole comprehensive suite of things to look at to really understand the community and to understand the equity implications of transportation decisions that are being made. And again, just to underscore that idea of having a holistic understanding of communities, the TD Population Index plays a role in a multi-pronged approach to understand transportation equity. And there are other data sets like health disparities data, information about transit ridership, maybe the stops with the greatest activity, so onboardings, alightings, network characteristics, so bike ped level traffic stress, or LOS for vehicles. Those are other things that can be looked at as well, in addition to the index, to really understand the transportation experience of the people living and traveling in an area. And of course, another data set that maybe some might not say is data, but certainly is qualitative data, is the actual stakeholder meetings and the discussions that are happening with the community. And that could, based on the project, range from a presentation, listening session, right, if it's a larger group, or it could be small group discussions and stakeholder meetings that are much more intentional, or maybe charrette-like, thinking about solutions with the community. So that's also data, understanding the lived experience and really understanding the background of what people go through on a day-to-day trying to use transportation, just trying to live their everyday lives. And really all of this data together paints a picture of the people that live in a community, and it provides a much greater insight into making equitable transportation decisions. And with that, here's my contact information if you would like to reach out and just ask me more about this presentation or equity in transportation planning. And thank you very much.
Awesome. Thank you, Segal. It's really exciting to hear about moving beyond just thinking about transportation as moving cars around, but really the community at large. So at this time, I am going to pause my screen. And if panelists would like to turn on their cameras, we can bring up our cameras and have a panel discussion before doing some Q&A from the audience. All right. So the first question that I wanted to ask the panel is, what do you feel is the biggest challenge to implementing health and equity into a transportation system?
I can start with that one. Was thinking through this question a bit, and I think the first one is really understanding what equity means for a specific community, since it could be very different across geographies. You might have certain population group, maybe there's more elderly persons or persons with disability in a community versus there's a different set of transportation or mobility challenges elsewhere. And I think equity is really understanding that it's not the same criteria across places, but it's very specific to one place is the first step. And then I would say another first step is just having a community connection. So we're making these decisions, these transportation decisions and investment in places that are, and these decisions are affecting people's lives, their ability to get around. And I think just having that relationship, whether it's community liaison or a leader, or folks just knowing how to reach out to the entity to have comments or questions, just establishing that relationship could be really, really beneficial down the line as just building trust and doing good work to make everyone's transportation lives and overall lives better.
Awesome. Thank you, Segal.
Yeah, I'll add to what Segal just said too. I think it's that continuous process of balancing. So with our tool, a lot of times what we're looking at is where could an intervention, where could a project have the most impact? And that's not to say that other areas don't have an equal or greater need, right? So kind of balancing that impact versus need, which is, even without the model, is a decision-making, burden that we all have in planning and resource allocation, especially within transportation, right?
I'll continue on that same thought, kind of taking it to that broad conceptual concept that I introduced this health, is that getting people thinking about that these tools, these influences, these minds, these way of thinking all factor in, that it's not just up to the individual to care about their health, but it's up to the community to care about everyone's health, both at the individual level, but as that community, and shifting that concept of this health so that we're having these discussions, these awesome discussions, not just here at a transportation, but also at a healthcare center, at an office, at that each part is a solution and a contributing factor to the overall plan.
So the idea that you're only as strong as your weakest link. And so we have to all build together. So jumping off of something that Roberta had mentioned is, you mentioned, allocating resources. And when I was thinking through some of these questions is, I feel that in order to progress these ideas and get further and build these projects that ultimately they're going towards, transportation funding is going to become an issue if it's not already an issue in your area. Um, and so when you guys are working with communities with these two tools, um, what are some of the first steps that a municipality can do that might not necessarily be those big ticket items, such as building a massive trail system or adding a BRT or what have you? But what are some first steps municipalities can take to incorporate equity and health in their planning efforts?
So I think it's really important, and Sigal talked a little bit about stakeholder, right? Having that lived in experience to, and particularly with health, I think that once a community sees how it will impact them, their health, it changes the narrative a little bit more. So, kind of a little bit of education, but just including that local level uh, community stakeholder to kind of get buy-in for a lot of the projects, right? But um, it doesn't necessarily answer the the question of resource and funding for a lot of the transportation projects, but at least it it gets kind of that the mental and the cultural buy-in, I think, from a lot of our communities, which can hopefully lead to that, right? Can get the support at the local level to lobby for some of these projects to be put in place, whether it's trails or complete streets or improved crosswalks, so that people are more likely to utilize the sidewalk and cross the street. Um,
Yeah, and I'll add to that we are undergoing a task now of doing a sort of equity audit in a study area, and part of that audit actually takes a look at um, transportation investments that are being planned for the next 5 years and looking at essentially TD population, but specifically uh, through the lens of racial equity. And we're trying to understand who is using those corridors now. And if more money is going into these specific corridors, is there a disproportionate amount of investment or disinvestment happening on corridors that are used by minority populations, for example? But we're also that's only one part of the audit. The audit is also looking at where are there existing pedestrian facilities, where are there existing bike facilities, where do we have the highest amount of transit ridership, where do we have the most crashes and the most severe crashes. We're looking at a whole subset of data and comparing that between essentially minority and non-minority populations. And it's very kind of a crude or blunt first take analysis, but I think a municipality just doing that audit in the first place is an investment in trying to understand their community and their area. And then from there, that tells a story that can be brought to the board or to the decision makers and say, these are numbers, this is data, this is what's happening. What does this mean looking forward?
So to continue on that same thought, I agree with this data aspect and that looping in your community, but don't forget, and I think this happens sometimes as you guys make these decisions, but going back to that community to tell them what decisions were made, how you guys want to, because 5 years is a long time in like a communities, you do these audits, you do these things, and then they don't see anything for those 5 years. So kind of that educational piece that this is going to take a process, that this is going to be time, and in keeping those stakeholders and people involved and educating them along the way, I think goes hand in hand to that resource like you're talking about for people to continue to advocate, to educate, to support these initiatives so that this funding continues, not just in the design phase, but in the implementation phase and into the final phase that people actually get to see and enjoy.
I think that's a really great point, Angelica, and I'm actually going to put Abby on the spot didn't tell her she was going to participate in the panel questions because I wasn't planning on it till right now. But jumping off of what, actually a little bit of what everyone's been saying over the past couple minutes is, Abby, could you speak a little bit about the struggles from the public involvement side and some, lessons learned as far as engaging transportation disadvantaged and populations and ensuring that you're communicating equitably while helping us planners speak non-planner languages.
Sure. So I think that question's a little twofold. So when it comes to making sure that we have our communications and our public engagement activities are equitable, a lot of it boils down to you need to go to that community. I think a lot of times in government or in transportation planning, MPO world, there was this old idea, they will come to us. And we're slowly learning, especially over the last 2 years with COVID and having virtual events, that really it's important that we go to where they are, right? So when we couldn't physically be together, where did we all go? We all went to this virtual sphere, and now it's kind of become the norm. But as far as our planning efforts and how it's changed over the last couple of years, we ensure that whenever we're doing a roadway, a corridor study, or a master plan update, that we make sure that we go to those communities, whether it's taking a transit bus and handing out surveys on the bus, actually doing surveys with them. We make sure when we do corridor studies that we list places that have free Wi-Fi that they could go and participate if it's a virtual event. So by brainstorming together and looking at different ways that we can be equitable across the board, it's elevated our processes and kind of always made us now think what piece is missing. And there's always work to be done in public involvement. There are a lot of gaps. And so we're just trying our best to fill all those in.
Awesome, thank you. So last question for the panel, and then because I want to be able to open it up to our attendees to get to ask some questions. So how does planning for health and equity help with transportation safety? Basically, how could we relate this back to the concept of Vision Zero?
I think it starts with accessibility, right? So the more accessibility of safe facilities, whether they are roadways, sidewalks, bus shelters, is really important, right? So, and even through our tool that we are looking at chronic disease too. I think safety with Vision Zero, safety starts at kind of just the comfort level and the reliance of our transportation facilities.
To piggyback off of that, I think it goes to that research. Research consistently reports that if people perceive they're safe, their health actually improves. Is in going back into those hierarchy of everyone needs in my presentation, everyone needs peace, shelter, food, income. So when you establish those very core components of like shelter, safety, then you can start to focus on your things like, how do I feel? How am I eating? How am I nourishing my body? How am I getting my food? How am I interacting with my neighbors? How clean is my air? All of those things start to become a priority when you're no longer looking at your core factors. So I think when you start to address things at this like kind of systematic level, that perception of safety increases, which naturally increases individuals' perception of health, and vice versa. When they feel healthier, they feel safer. So one of the things they did in a recent study was they started just having individuals walk their dogs through the neighborhoods, and the safety rating increased by 10% just by the perception of seeing someone walk their dog. Didn't matter if they were an actual real neighbor or not, it was that perception of safety was associated. And so I see that there's this correlation with that healthy behavior and safety tied with everything. So I think when we look at these things as, again, that's complex system, they go hand in hand. So we want to reduce this, crime, we want to increase the transportation, we want to increase health, like all these things support each other.
Yeah, and I'll just add, I think the big points have already been hit, but I just understanding the intersection of things. So where people are going to work and where people, if you're understanding the health data, understanding the nearby hospitals that are being used and understanding where people are going to get their food. Maybe it's a food desert. And, there's just so many intersecting variables that make up where a person is trying to get or come from or travel. And I think if we can start to understand how all of those things interact with one another, we can get a better sense of where are maybe the places that need, because there's always prioritizing with a limited amount of funds available, right? So where do we prioritize where these funds need to go based on where people who have historically been left out of the conversation or historically disinvested in are going. And so I feel like it's just as Angelica was saying, it's very looking at the holistic intersecting pictures of all these determinants will ultimately improve safety, I think.
Awesome. Great conversation, guys, and thank you so much. So, as I said, I wanted to give an opportunity for our attendees to ask any questions of our panelists. And so far, we do have one question in the question box. If you'd like to ask a question, if you could put it in the question box or raise your hand at this time. So our first question is for Roberta. And is there weighting or some way to gauge which improvement leads to a better / more impactful outcome?
So that's a great question. So, we don't speak of it as a better, but as has a stronger correlation, right? So a prevalence, a higher prevalence, a higher incidence. So yes, so some things that we have seen over and over. The presence of sidewalks had a higher correlation with people actually walking in their neighborhoods and that lower risk profile in communities, right? We kind of steer away from saying better because that brings kind of that interpretation, and then it also again back to causation, correlation isn't causation. It doesn't mean that if we go and put sidewalks everywhere, people are automatically going to start walking, right? Maybe not, but we are seeing that relationship, that correlation at higher incidences and higher prevalences.
Awesome. Thank you, Roberta. Do we have any other questions this morning? All right. Well, I would like to turn it over to, once again, I'd like to thank all of our panelists. Here is everyone's contact info that participated today. Thank you all for taking the time to join us this morning and to share your wealth of knowledge on health and equity. It's a really important subject emerging in the transportation world and also I think just across everywhere right now. But before we close out today, oh, wait, we did just have one more question pop in. So most of them are exploratory analysis. Any thought in conducting behavioral analysis?
So we have discussed and talked about that too, and it would really come down to, again, normalizing that data, right? So being able to get, and we do have some behavioral factors that we utilize, but being able to get that at the census tract level, and then for the comparative, being able to project it to other places. So it's a little tricky, depending on how specific that behavioral data is, but something like ridership, right? We could consider that a behavioral data, and that is available, and we certainly have utilized that before as well.
There's a clarification. I mean, conducting the survey to understand people's behavior.
So like, we have not taken it that kind of reverse route yet. We can input some of that behavioral data to understand the relationships, but not determine the relationships, right? So again, you know, we can make those assessments of, you know, wider road widths might have more trails or bike lanes, but that doesn't necessarily imply there's more people riding bikes.
Awesome, thank you. All right, so as I said before we close out, I wanted to give Abby the opportunity to speak a little bit on Mobility Week and finish up some upcoming activities that we'll be doing this week.
Awesome. Thanks, Sarah. So yes, if you didn't know, it's Mobility Week. So we have lots of great events planned for the rest of the week. Of course, we had our webinar today. Today is also for Space Coast Area Transit. It's Tri-Transit Tuesday. It's also Election Day. So you can ride free all day on Space Coast Area Transit. And that's really exciting to go and cast your vote. And then tomorrow we will be having a tweet chat at 1 p.m. If you don't follow us already, our profile is Space Coast TPO on Twitter, and tomorrow we will be chatting about roads and modes, the benefits of complete streets. Then coming up on Friday, we have our Safety is Golden Mobility Fair. This is geared towards senior citizens. We are partnering with the Central Viera Community Association. Citizens will enjoy an interactive showcase of local and state vendors for mobility resources and information. And it's just really all about safety. We'll also have some traffic safety expos happening at the same time. So if you would like to attend, or you know somebody in our area who would, the registration link is right there. And then Space Coast Area Transit will be having a discounted rate for the local state fair from the 5th to the 21st. Then we have a couple more events on the next slide. And then we will be closing out Mobility Week on Friday night, November 5th. We will be partnering with Cape Canaveral. They have their Friday Fest. We'll be talking about, again, the benefits of complete streets, pedestrian safety, and giving away some goodies. And then on Saturday, it's our last event. We're partnering with Space Coast Area Transit. The city of Satellite Beach is hosting their Founders Day Parade and community event, and we'll be there talking safety and giving away some goodies. So that should be a very fun event. If you'd like to know more about Mobility Week, you can visit the FDOT website. And then now through the early December, we are coordinating with Space Coast Area Transit to launch a survey. So whether you take transit, whether you bike, walk, or you're a driver, we'd love to have your input. We would like to know what would make you ride transit if you don't already. And if you do ride transit, what features are you liking and what would you like to see more of? So please make sure you can visit our website. It's all over our social media pages. So please make sure you take the survey. And then we have another event coming up in November. Our moderator, Sarah Crum, who's also our senior transportation planner, will be leading our Transportation Thursday webinar series. This is a series that we've been doing quarterly, and her topic will be the future of transit service. So we're really excited to hear more about that. And then shameless plug, if you're not already, please make sure you follow us on social media, on Facebook, Twitter, or YouTube, and please go check out our new redesigned website. It's very user-friendly, it has very equitable, and it has lots of great resources on there. So if you have not visited our new website, please make sure you go look at it. That's all I have.
Thank you, Abby, and thank you once again to all of our panelists and to all of our attendees for joining us this morning. And with that, I hope everyone has a very happy Mobility Week and go out there and try a new form of transportation this week. So thank you.
Thank you.
Thank you, everyone.